Yeah, we're going to talk about the menopause, and you can move forwards again. Right, so what are we going to cover? So we're going to cover just a tiny bit about who I am and why today. What is the menopause? Would be a good start, wouldn't it? Why does it happen to us? A little bit about the science. Symptoms, treatments, kind of useful. The big elephant in the room, HRT and breast cancer. And actually how we should carry on living life to the full despite the menopause. And what next? Right, so, and some questions and answers. So, next slide. So who am I? So, I'm Fiona, lots of you know me. I'm Dr Fiona Kennedy to most of my patients. I currently work as a GP down in Paddington. Previously, I worked as a GP partner over in East London in Bethnal Green, and before that, I did a range of different jobs. So I qualified as a doctor back in 2001 and did my GP training and qualified as a GP pretty much the year that Toby was born, so about 2005. I'm interested in lots of different things, but I will explain to anyone who's interested later about social prescribing, but it does come a lot into how I approach the menopause. I've got an interest in menopause and musculoskeletal issues, and looking at trying to put the whole picture together, so something that I would call holistic care, which is what we all try to do in 10 minutes. So my interest in the menopause started in 2013, and I don't know whether any of you have had this experience yet, if you've been to see a GP about the menopause. So I had some teaching about the menopause during medical school, because during medical school we were told HRT is good and it can treat women with menopausal symptoms. However, I qualified 2001, just as two massive global studies were published. The Women's Health Initiative and the Million Women Study, which said, HRT is bad, don't prescribe it. It's going to give women breast cancer, they're going to get increased risk of heart attacks and strokes, don't give it. So suddenly you're going, you've come in here and you want HRT. Okay, you understand the risks? It's going to cause breast cancer. Okay, you've got a womb, so I need to use estrogen and progesterone. And I would turn to our trustee. This is the latest BNF. This is the British National Formulary of all the drugs that we can prescribe. And you turn to the relevant page about estrogen and progesterone and make sure that you were giving the right form. But you suddenly realize there are different forms of estrogen, different forms of progesterone, and you're trying to work out which one is right for this woman. You're like, I've heard of this one before, we'll try this one. And suddenly I realized there's something that in the GP land, this is where Karen and Kerrian will know what I'm talking about. There's something called puns and dens. A pun stands for a patient's unmet need, and den is a doctor's educational need. So I promptly went on a course about the menopause, realizing that I needed to up some knowledge. So that's what I did in 2013 and was so excited about what I was hearing. I wanted to do more. So I went on and did a 2-day residential course, which is very good when you've got a 2-year-old daughter at home to disappear off somewhere and do a 2-day residential course, learning about the theory and the practical prescribing during menopause. I continue each year to do courses on the menopause to stay up to date because there are still all these studies being published. And I am not a gynecologist or an obstetrician. I am a GP with an interest in the menopause, but I am not a specialist. So please go and speak to your GP or your obstetrician or your gynecologist for further information. And the hotspots, when I was in Bethnal Green, very excited about all of this, which is when my interest kicked off, our patient group at our surgery, we help them form the hotspots. So in Bethnal Green, there's a group of patients in patient participation groups in the GP surgery promoting what the menopause is to other women, and they would chat to women in the surgery waiting room. That was a large Bengali population where often women presenting in their 40s, 50s with pain all over and various symptoms actually was the menopause, and they hadn't really heard about it or understood about it. So we promoted hotspots, and then they managed to get some localized funding from public health, and it's still going strong, and they meet for coffees, sometimes, or herbal drinks. They've started a walking group, and it's going great guns. So there's an inspiration for all of you to go out and do something if you want to. So enough about me, and so hence today. So this is a survey, a national survey that was put out in 2016. And I'll just summarize a little bit about this. So 50% of women between the ages of 45 and 65 will go to see their GP or a doctor about the menopause. But that also means that 50% don't. So it is an issue, and half of us women will go and see a doctor at some point about the menopause. So more than a third of women say that they struggle in the workplace, and those of you who are Guardian readers or seen stuff on the BBC, there's a lot of stuff going on about menopause and its effect in the workplace, and how women, and we'll talk about this a little bit later, but actually women aren't necessarily getting the support when they need it in the workplace, and sometimes it results in people leaving their jobs because of it. Again, we've got 50% say it affects home life. Never seen that happen. And 50% say that it does also affect their relationships and their sex life. Okay, next slide. Okay, so we'll run through a couple of quick things to get the definition correct. So the menopause actually comes from the Greek word meaning menos, which means month, and pause, to stop, hence the menopause. It does not mean a pause from men, although obviously it does have a major impact on relationships, if you were in one. It can only be dated in retrospect. By that I mean that we say the menopause is the date upon which you have not had a period for 12 months. So you only know when you haven't had a year's worth of periods. So up until that point, we call it the transitional phase, or the perimenopause. You may have heard of the older words, the climacteric phase. And then after that, we call it postmenopause. So that's where and the menopause can be natural. So when our own bodies naturally go through the menopause, and this is usually more gradual and fluctuates, or it can be medical and surgical. So medically, when a woman is given medication for either breast cancer or for very awful endometriosis or fibroids, when we're telling the body, stop, this woman needs no more of this, she cannot cope. And obviously for breast cancer, it's because a lot of breast cancers are stimulated, have got receptors in them, which are, so if we've got extra estrogen going, it promotes the growth of a breast cancer. So we use estrogen blockers. And surgically, some women, unfortunately for a number of different reasons, may have had a total abdominal hysterectomy, so had the womb removed, and sometimes their ovaries as well. So if your ovaries are saved, then often it means you don't go through the menopause at that stage, but you will often, interestingly, go through a menopause slightly earlier than you would have done naturally if your womb was still in place. And the treatment for a woman who has had a surgical menopause or a medical menopause, we need to be aware that these women will have been in hospital sometimes, had an operation, sent home, and they'll be warned, you might get some symptoms, you may want to go and see your GP. Within a few days, splat, they are into the worst menopause symptoms straight away. There is no little fluctuating. Similarly, if women have had to be put on tamoxifen, the symptoms can happen quite abruptly and quite quickly, and often, sometimes at a much younger age. So, when? Now, the average age at the moment in the UK is 51, but the range of average and considered normal is between about 45 to 55, 53, 54, 55. Okay. But the symptoms can start up to 10 years before you go through the menopause, this perimenopause symptoms, and it doesn't stay flat. Sometimes you'll go through a few months and you think, oh my goodness, am I about to go into the menopause? And then you have 6 months when everything is fine and your periods are tickety-boo and everything is fine. So up to between 40 and 45 is considered an early menopause. Below 40 is considered what we now call a premature ovarian insufficiency, which previously used to be called a premature menopause, which is really, really upsetting, and there really isn't enough support for these women. And obviously, a surgical menopause can happen at any time. Thank you, Grace. Sorry, I've got a slight. Sorry. Perfect. Yeah. So, and the next slide, please. So So why does it happen? Why does it happen to us women? Well, it's basically down to this hormone called estrogen and the fact that actually eggs. Unlike men who carry on producing sperm throughout their lifetime, we as women are conceived and we have the oocytes, the premature form of the eggs, right from the moment when we are conceived and into about the 5th month of development in the womb, okay? And at that point, we have about 7 million oocytes, or the very, very early cells. By the time we are born, we're down to 2 million. By the time we hit puberty, it's even less. And by the time you get to your 40s, it's even less. So we have a set amount of eggs that we're born with, and we will go through the menopause when those levels of eggs get very, very low. Now, interestingly, a tiny little bit, you're kind of thinking, but we don't have periods from when we're born. Well, when you're born, up until puberty, your eggs kind of go into not a frozen state, but they sort of stop any further progression until you get the introduction of the sex hormones that happen during puberty, when then suddenly things start to kick off. So that's when you start having your periods. But we're in a constant state of loss, and some of us will have a few more thousand than some other people in the room, but we are in a constant state of decline of being female. There we go. That's a bit of embryology for you, which I think is quite fascinating. Anyway, so this menopause transition, perimenopause time, which is the very variable time, is all because we are getting less stimulation from the ovary because there are less eggs. And we will go into the next slide, which looks a little bit at the sort of chemistry which is going on with the estrogen and the progesterone. But basically, the system is that if you haven't got very many eggs, you're not producing much estrogen, which therefore isn't stimulating the pituitary gland properly, which isn't then allowing ovulation to occur, so you're getting some hot flushes, before your periods start becoming a bit erratic, and you might notice that you're getting more moody, and when you do have a period, your family know about it because you feel more moody. So you're just noticing that things are just beginning to get a little bit out of sync. And then you get to the stage of missing a whole period, and then gradually that happens, and then you think, hey, my periods have stopped, and then suddenly you're like, it's happened, because it comes without any warning, and often it can be very, very heavy, because the cycle length could be quite long, so you get the build-up of the womb lining for longer, and then when it does shed, oh boy, does it shed. So we're noticing everything fluctuating during this period. Thanks, Grace. And finally, we enter the menopause. Right, next slide, please, Grace. So this is a little bit now, you might have seen this once upon a time in a biology class if you did GCSE or A-level biology. But basically, this is just showing our menstrual cycle. And if I can use this pointer, here we go. So menses means period, and I always have to keep on reminding my husband, even though he's a qualified doctor, that actually the monthly cycle starts on day 1 here when you start your bleed. Okay, so we class the month from the start of bleed. So when a doctor asks you, what was the last date of your last period, your LMP, they're asking what was the first day of bleeding. Anyway, so as we go through the month, you can see in the ovary, we've got the oocyte slowly developing and then growing, and then we've got the egg being released at ovulation. We then get a cyst developing, which is called the corpus luteal cyst, and that slowly degenerates. If pregnancy occurs, which would occur around here, then you can see this is where the progesterone level is high. The progesterone is what maintains the pregnancy and keeps the the womb lining thick, and this will then continue. But if there is no conception, if the woman doesn't fall pregnant, then the hormones all fall, and we go into the next cycle. And you can see that these are the hormones which are produced by the pituitary gland up in the base of the brain, which then sends down messages down to the ovaries, where we've got the production of progesterone and estrogen. Progesterone predominantly being produced by this corpus luteal cyst, the estradiol, the estrogen being produced in the ovary by the developing oocyte, and the estrogen is needed to then tell the pituitary gland what to do next. So it's on this feedback mechanism loop. And if you can go to the next slide, please, Grace. Now, some of you who may have thyroid disease and other diseases as well, our bodies are phenomenal. They really are incredible. And if you are an endocrinologist, someone who studies hormones that go on in the body, thyroid hormones, all the others, a lot of our body works through what we call a negative feedback loop. So if your body is producing enough of something, it tells the brain you don't need to produce any more. And then there's sometimes a positive feedback loop as well. But it's in this cycle, so everything needs to be working properly for you to have normal periods. So the same for the thyroid, and that's why we look at thyroid-stimulating hormone, TSH, and free T4. And that's why when you go to the doctors and they sometimes do tests around the menopause, they may be testing for this FSH, this follicle-stimulating hormone. And basically, this hormone will go up as you're entering the menopause, because your brain is saying, come on, ovaries, you can do it, just one more egg, you need to reproduce, the world needs to keep on going. So this is why we test for this FSH here. But if we can just flip back to the previous slide, Grace, you may have been told, or women may have been told, you're not in the menopause, it's okay, your FSH is low. But this is because, obviously, during your cycle, your hormone levels fluctuate, as do your symptoms. So you'll have 1 month where your FSH levels may be doing what they're meant to be doing, and then you'll have another month when they're not. So depending on when your GP or the doctor tests you, it may be high, low, somewhere in between. Also at this time, we usually are asking women to do these tests around day 3 to day 5. But if you've got an irregular cycle, how on earth are you going to know when day 3 or day 5 is? And if you haven't had a period for several months, you're like, now? So it's really difficult. So what we would generally say, if you have symptoms and you are young and you've had a questionable result or you've had a result which doesn't seem to make sense to you, the recommendations by NICE, and we'll go into this a little bit, is to get another test in 3 months' time, okay? Because one figure doesn't mean yes or no. The other thing is we shouldn't be testing, and these are NICE guidelines as well, we shouldn't be testing for these hormones over the age of 45. They fluctuate too much, and actually, if a woman over the age of 45 has symptoms of the menopause, an irregular period, unless there's some other weird thing going on, they are menopausal, okay? So we shouldn't be doing blood tests. We should be getting on and looking after this woman. Okay, and we can flip over this slide, thanks Grace. And again, this just shows, and sorry, yes, taken from the internet, this just shows the estrogen levels rising throughout into puberty, then oscillating through our cycles. If we're pregnant, the levels go up, and then gradually keep on cycling, and then estrogen levels slowly falling, and it isn't such a nice, pretty slope. It kind of does this and then dives down. So it isn't in a steady free fall state, which we might be able to cope with more, but it's the fact that it's fluctuating. Right, next slide, please. Right, this is a bit to see if you're still awake and if you've had enough coffee this morning. So if people want to shout out, I don't have a roving mic, but I will repeat what people say for the purpose of people online. Any thoughts, symptoms? Symptoms you've had, having, think you might have?
Serious brain fog.
Brain fog, brilliant. Okay, anyone else?
Restless sleep.
Restless sleep.
Hot flushes.
Hot flushes. Painful joints. The doctors might call that arthralgia, but yeah, painful joints.
Feeling you're a different person.
Yeah, feeling completely out of sorts. Completely out of sorts. Anything else?
Dry skin, dry eyes.
Yeah, definitely. Dry skin, dry eyes. Low mood. Sometimes anxiety as well. Anything else? Yeah, weight gain, bloating. Breasts get bigger around your perimenopausal time. That can be a bit of a concern for women, thinking, oh, my breast's getting larger, what's going on? Become more tender. Yeah, anything else? Yeah, so generally your repair of things can take longer, and certainly things like sports injuries can take longer. And you're more prone to sports injuries and tendinitises and tendinopathies and all that kind of stuff. Anything else? Yeah, muscle aches and pains, morning stiffness, all of that. Thinning hair. Muscle loss. Thinning hair, and then also the unwanted hair in the wrong places. Yeah. Anything else? Okay, so we're going to show a list of just some of the symptoms. So, night sweats and hot flushes, those are the two main ones, and those are what we as doctors call the vasomotor symptoms. These are the big two, and if you have these and irregular periods or no periods, you're menopausal. Okay, dry skin, acne, again, you thought it had all gone away, afraid not necessarily. Itchy skin, now this does say formication. Okay, that's the sensation of insects crawling underneath your skin, okay? So, fatigue, brain fog, memory loss, emotional irritability, anger 1 minute, tearful the next, sore breasts and bloating, weight gain. We've talked about the hair loss in the places we want it and not in the places we don't want it. Lack of libido, so not wanting sex, to be honest, truth, would actually just prefer a nice cup of tea. And a cool bed, aching joints, joint stiffness, muscle loss. And if you're like me, showing that your Strava times are getting worse. Right, next slide, please. And sometimes this is just for a little bit of a joke. So this is, you can find this on the internet all over the place. It's called the 7 dwarfs of the menopause. But as one video blogger said, it should be called the 7 gremlins of the menopause. Because in Snow White and the 7 dwarfs, these are all people that helped her. And yes, there was dopey and forgetful, etc. But her comment was that when you go through the menopause, these gremlins seem to invade you. So we've got itchy, bitchy, sweaty, sleepy, bloated, forgetful, and psycho. Right. Okay, moving on. Thank you. So, we could think, and hopefully now you're beginning to get an idea, that estrogen isn't just all about periods. You have estrogen receptors around all sorts of places in your body, and they control more than just your periods. Okay, so it improves skin elasticity, so the dry skin, poor wound healing, muscle problems. Promotes reproductive health, yes. It preserves bone density. This is massively important. We'll come on to that in a minute. It does regulate the menstrual cycle. Now, heart. Who thought about estrogen and the massive effect it has on our hearts? Up until the menopause, we women, hallelujah, have a lower rate of heart attacks than men and strokes because of estrogen. After the menopause, we have the same rate as men, but a poorer outcome. Because we often present slightly differently. We don't have the classical symptoms, and we're often poo-pooed, oh, you're a woman, you don't get heart attacks. And the evidence that's coming out, and this is one of the big take-home messages, please, women, is the fact our hearts matter, and as we go through the menopause, we need to be looking after them. All right? So we'll come on to that. The brain. So estrogen isn't the only reason, and the lack of estrogen, why we're getting the hot flushes, but it is important in temperature regulation. It's really important in these blood vessels. So estrogen keeps the elasticity of the blood vessel lumen, the vessel lining. So a lot of the problem with the first studies, and I'll just explain this briefly now, and I know it's a bit of a digression. The 1 million women studied in the Women's Health Initiative, one of these studies was giving pretty massive doses of estrogen and progesterone to women of all ages, including women in their 70s, who potentially had never had HRT before. We don't give those doses anymore. Now, if up until the age of 50 you've got lovely blood vessels which are nice and flexible and reduce your risk of cholesterol plaques flying off, you then have 15, 20 years of those blood vessels slowly hardening. You then give them estrogen again. You make them lovely and supple and soft. The cholesterol plaques are going to fly off, and hey presto, you're going to have an increased risk of heart attack and stroke. So what we need to be aware of is this gap of allowing a woman's blood vessels to harden and then giving it again, which is why those studies were showing that there was a massive increase in cardiovascular disease. So we wouldn't now be giving a lady in their 70s who's never had HRT before a whopping great big dose of HRT, because we know that is rubbish for their hearts. What we do know is that estrogen is good for heart. So we just need to balance that up. So yes, it stimulates breast development, it maintains vaginal thickness and vaginal lining, and it's so important for the bones. Now, I'm really sorry, women. We are all women here. I think Mo's downstairs somewhere. I am just going to briefly mention the vagina, okay? We all have one, and it is really, really necessary because there is something that doesn't present to us in general practice enough. 70% of us will start to have issues with vaginal dryness, vaginal soreness, feelings like we've got a urine infection, but then you go to the doctor and they say, no bacteria there, no infection, or the male GP who just dishes out antibiotic after antibiotic after antibiotic. So it is necessary. Also, the estrogen in the vagina doesn't just make the lining nice and soft. If you kind of think about it, and this is where I describe it to my patients, so I apologize, it's the lining of your vagina is a bit like the inside of your mouth, nice and moist and supple. As you go through the menopause, it starts to dry out, so it's much more fragile, which means sex can become really painful. But it also means that you haven't got that lovely protective barrier for infections, so you may oscillate between thrush and bacterial vaginosis and thrush and you are going to be more at risk of infections. But also, it's important for the support structures. So whether you've had children or not, you've got something called a pelvic floor. And I'm sorry, we're all women, but it basically starts at your pubic bone at the front and finishes at your tailbone at the back. And it's like a hammock, and it holds everything up. As you go through the menopause and there isn't the estrogen there to keep that nice and strong because it is a muscle support, it's not just one muscle, it's a group of muscles, it starts to fade a bit. So you might notice that when you run for the bus, you kind of come a little bit unstuck, or you laugh really loud at a child's joke or something, you're like, just gonna have to cross my legs a bit. So we have to be aware, whether you've had children or not, and children and childbearing and poor deliveries can make this problem worse and tip it over the edge, but our pelvic floors are important. Anyway, sorry, enough about vaginas. Right, moving on. Okay, now, you thought you'd coming to talk about menopause. I just want to throw this in here because this usually stumps most of my patients when I talk to them. What do you think, you as a woman in the Western world, more likely to die of? What do you think is the number one cause? If you live long enough. So I'm not talking about early. Any answers? Don't worry, there isn't a rubbish answer. Cancer? Heart? Dementia? Old age? Yeah. Right, okay. Thanks, Grace. So this is a study that was published in Australia. I think we can extrapolate, and it's 1999, so just pre-pandemic. So number one is dementia. Congratulations. So dementia is our number one, because if we live long enough, we will most probably, and also Alzheimer's disease. Number two, well done, coronary heart disease. Heart disease is your number two killer. Number three, strokes and other related brain illnesses. Then we've got chronic lower respiratory, so those are most probably more the smokers, but actually pneumonias as well. Lung cancer is number 5. Then breast cancer. Okay, so breast cancer is number 6. Then we've got colon cancers, influenza, pneumonia, diabetes, that's increasing, and then diseases of the urinary tract. Now, I've heard a recent talk, and please, 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 women, bladder cancer in women, again, partially because of the menopause, is known as the Cinderella cancer. It's the one that doesn't get much funding and is the one that's not much known about. So if you have unexplained blood in your urine, please get it checked out by a GP. Right, and next slide, please. So, I'm hoping that's put a little bit of a few thoughts in your head and hope it's helped you sort of balance out a little bit more where breast cancer risk is, and actually, oh my goodness, my heart. How am I looking after my cardiovascular health? Right, so cardiovascular disease, we've mentioned how the estrogen affects our risk with cardiovascular disease, and yet we have the 40s NHS health check, which actually disappeared because of the pandemic and the stress, but you went to your GP at age 40, you were invited for an NHS health check in the olden days, and we checked your cholesterol, etc. Well, if you do that on most women aged 40, their cholesterol is mostly going to be okay because they've still got estrogen and everything else going on. But it's actually what I would recommend to women who are menopausal is actually asking your GP, could I please have my cholesterol checked and my risk of diabetes checked now, particularly if you've got a family history of this, because now is the time for us to assess your risk. because now is the time we can see what is really going on and make sure that we are doing and helping you with the right treatments. Okay, this I haven't talked about much yet, but this is really, really important. So osteoporosis. Osteoporosis is when the bones get super thin to the point that you're at a high risk of fracture, usually in the thigh bones, but you can have crush fractures in the vertebra, which are so painful, and I've got a lot of elderly patients with that, and it's really hard to treat. Osteoporosis, so as you go through the menopause and your estrogen levels fall, unfortunately that causes your bone loss to start accelerating. So you lose bone density. Okay, this is really important because if you can think about it, the earlier you go through the menopause, the faster the rate of your drop of bone loss, and the more likely you are to end up with a bone loss that is going to end with osteoporosis. So for women who go through an early menopause or a premature menopause, again, looking at our estrogen levels is really, really important, and considering HRT in these women, because otherwise they are at risk. There are other treatments out there, and it may not be appropriate for everyone, but we do need to look at this osteoporosis. Okay. And then we've talked about the vaginal atrophy and urinary incontinence, so please don't be quiet about it. Please go and see your GP, and unfortunately, it seems to be about 70%, and yet I certainly don't see 70% of my women presenting with this until it's very late on. And what we would, have I done, no, Squeezy app, so I'll put a link at the end, but there's something called the Squeezy app, which you can download off your app store, which is, I think it's $1.99. It was developed by women's health physios down at UCL in partnership with the NHS, and it goes through as a reminder to do your pelvic floor exercises every day. But there are other apps out there, and the NHS website has also got links to pelvic floor stuff. So when we're looking at this, we're looking at also risk factors. So with your GP, and if you have risks of family history of heart disease, family history of osteoporosis, we often think of the little sparrow type person who's got the thin bones and is light, and mother had osteoporosis and grandmother had osteoporosis and they broke their hips. But also if they've been on steroids for a long period of time, if they've been smokers, heavy drinkers, and we also want to look about exercise here as well. So we're looking at your risk factors for these things, then putting things in place. And if you've had some bad deliveries and likely to have damage down below, get onto your pelvic floor early. Right, next. So, treatments. Now, just going to very quickly explain this little symbol that's out there, because I'm not going to dwell on herbal supplements, only to say that some herbal supplements, you can use them. Look out for the THR symbol. This is the recommended symbol that means that it has been given some approval by the European Union. So don't use a herbal supplement that hasn't got that on. The other thing to say is that some herbal supplements are not, they have interactions. So please be aware that some of these herbal supplements do have interactions with cancer medications, antidepressant medications, and other medications that can affect the liver. So you might have heard about things like black cohosh, and my mind's gone blank of a whole load of it. Yeah, St. John's wort in particular. So St. John's wort, be careful. Black cohosh, be careful. Always speak to your GP if you can about these things before you go on them. It's not to say that you can't, but we need to just check. Now, I am going to dwell on some of the non-medical stuff because very easily this talk is going to become HRT. So, non-medical, and I want to really recommend, and I'm going to give you the link, it's in your bags in a little piece of paper. The British Menopause Society has produced a leaflet, and their patient website, which is the Women's Health Concern, which again the link is in your bags, has a link to CBT. Now, I've increasingly had to say this very carefully when I'm doing telephone consultations. So, oh, CBD, yeah, I can get that down the high street. No, I'm not talking about CBD. I'm not allowed to recommend or not recommend CBD. I'm talking about CBT, Cognitive Behavioral Therapy. This is where we can use talking therapies, but particular tools to try and de-escalate a hot flush. And there is now good evidence, and they've done studies looking at breast cancer patients who can't have HRT and showing that we can reduce the length and severity of a hot flush if you use these CBT techniques. So there is a downloadable information sheet that you can go home. It'd be some nice bedtime reading for when you can't sleep, and so you can have a read of that. So CBT, but also recognizing that the anxiety around the menopause and other things may need you to seek some psychological help as well. Lifestyle. So we've touched on this a little bit, smoking, drinking, etc., and we'll go into it a little bit later as well. But lifestyle, being aware that how we use our bodies is really important. As someone mentioned about the muscle loss, we need to be aware that as we're going through the menopause, we possibly need to change our diet slightly. And someone mentioned bloating and putting on weight. So we mostly need to change the balance between the protein and the carbohydrates. Okay, and possibly a slightly higher protein diet, slightly lower carbohydrate, guilty. And also we need to look at exercises that we can be doing and things that we need to be doing. So it's not just cardiovascular. It's strength training as well. And this is where I've got my little helper. So you do not need to go and spend loads of money and go to the gym. I'm just asking people to do some very, very simple things that they can be doing. Maybe when they're on a call at work and you're sat in front of the computer and your phone and your watch has buzzed to say, move, or whatever. But few things that we need to do. We need to make sure we've got strong core and glutes. We need to make sure our legs are strong, our stability is strong. And I've got a little link to Michael Mosley's Just One Thing. If you haven't listened to some of his podcasts or whatever, they're great fun. So on the BBC podcast, Michael Mosley, Just One Thing, and it's in your bags. Right, so thank you, Sue. I did prime her. So what I'm going to ask Sue to do is just keeping her knees pointing forwards, engaging her bottom muscles and her tummy muscles. It's just to stand up towards the ceiling, sit down and stand up again. Okay. So really, really simple, but really, really important. As we get older, if you cannot do this without using your arms to push you up or things like that, you are going to be at massively increased risk of falling. Okay? These are just a really simple tip that you can do. So it's going down, making sure our knees are pointing forwards, pushing back up. Okay? I'm not talking major gym equipment, but doing this routinely during the day when our muscles go to sleep, when we're sat over a computer or doing whatever we're doing, is a really good way of just engaging the core again and getting those muscles working. And the other tip, again, Michael Mosley speaks about this one. Sorry, Michael Mosley. Is a simple stability. As we get older, our balance reduces as well. So it's all about learning to stand on one leg, and Michael Mosley does a whole thing about it. So if you need to hold on, you hold on in front, not to the side. We're wanting to make sure the pelvic is nice and stable, and we're engaging it nice and strong. Because obviously, every time you walk, you're standing on one leg. If it's not strong, your poor little knee has to do all the work. If you then run, even more so. So one thing for you to be practicing at home, again, it's going to reduce our risk of falls as we get older. It's really important. It helps our brain, our muscles, and apparently when you get when you get really good, you can do it with your eyes closed. So just a couple of little things just to go on lifestyle, okay? Because I don't want to make this all into a medical talk about HRT. Thank you very much, Sue. You may sit down. Thank you. Right. Okay, medical. So we are going to look at the hormonal stuff, but there are also some non-hormonal medical treatments that are out there. Oh my goodness, we need to speed up. I'm so sorry. Okay, so non-hormonal, so sometimes women who can't use hormones, you can use antidepressants, which can reduce hot flushes, but obviously calcium, vitamin D are also really important, and we've got the hormonal treatments. Okay, Grace, sorry, next slide. I tell you, I get so wound up about this that I go on and on. Right, so, and next bit, thanks. So is it necessary? We need to treat each woman as an individual. We only need to treat if there's symptoms for someone who is going through the menopause at the normal time around 50s. Okay? If you are going through an early menopause, that's a completely different scenario, and we need to be thinking far more seriously about considering treatment, because as we've seen, cardiovascular health, bone health, etc., really important. Okay? It could be estrogen and progesterone, and for some women who've had their ovaries removed as well, they may need testosterone as well. Hormone replacement. I just need to make this clear. This is not the combined oral contraceptive pill where you have your own level of hormones and we add the hormones on top. This is hormone replacement that's bringing you back up to where your hormones would have been. So it's replacement. Okay, types, multiple different types, and we can cover all, I suspect there'll be quite a lot of questions about all of this, but basically it can be oral, it can be a patch, it can be a gel, you can use coils, you can use injections, there's now a spray, you know, the world's your oyster. But also for some women, it needs to be continuous, where you don't have a bleed, and some women who are younger, we need to give it to you what we call cyclically, so that you have a period each month still. Okay, thank you. And there are obviously a few women who can't have it, if you've had breast cancer, for example. And some people with active liver disease and clotting problems. And the bioidentical, again, if people want to ask about that, we'll do that in questions and answers. Thank you. So, I am not ignoring breast cancer. I am not saying forget about breast cancer. All of us as women, please, please, please check your breasts regularly, at least once a month in the shower, at the same time each month, so you get to know what feels normal for you as they change during the month. And if you want more guidance, either check for cancer or there's Copper Feel that you can have a look on the internet. Next slide, please. So, HRT is not going to kill you. This was The Guardian last year. Again, there was another study that said, and this really upset a patient of mine yesterday, and if people want to ask about it, I can tell you about that later. But basically, this was saying, you are not, even if you get breast cancer, HRT is not going to increase your risk of death. Okay? HRT does not cause breast cancer. Because many breast cancers are hormone receptors, have got hormone receptors in it. It makes sense, just like if you're fertilizing a plant, if you give that plant more estrogen, it's going to grow more. So therefore, HRT does not change the cell DNA. It can't do that. What it's doing is feeding a tumor. Okay? So if you remove the HRT, the tumor isn't going to suddenly shrink, but it's not going to keep on growing at the same rate, and then you can have the medical, surgical treatment, etc. So just to make that quite clear, HRT does not cause breast cancer, but there will be more cases of breast cancer in those women who take HRT because it may cause a tiny thing to grow. Okay. And this is a slide just to say we are all different. And therefore, what I prescribe to one patient or don't prescribe to another is not going to be right for another. And as circumstances are different, and as time of life is different, so what we need is very different. Thank you, Grace. Now, this slide is probably the most important slide that I want to cover because I know that we are massively overrunning, and I'm so sorry, everyone. So, general population, this was actually done in 2017, I think. 23 cases of breast cancer over 5 years for women aged between 50 and 59. So per 1,000 women, over a 5-year period, 23 cases of breast cancer. If you are put on any form, so it's all the forms together, combined HRT, so estrogen and progesterone, 4 in more cases of breast cancer. Estrogen only, so thank you, Grace, this one here, estrogen only, they used to say 4 less. Actually, we don't think that, but we think it's negligible. So there's mostly no increase. So these are for women who've had their womb removed. So you can't have estrogen only if you've got a womb. 4 extra cases if you're still on the combined pill. How many of us remember to tell our patients about risks of breast cancer for those women who are on the pill? 5 cases, this is important, for those women who like a glass of wine every night. So more than HRT. Smoking, 3 extra cases. Now, I'm really sorry, everyone, but this is important. And this occasionally it gets published in the major newspapers. 24 extra cases if you've got a BMI of greater than 30. So if you struggle with your weight, the best chance of you reducing your risk of breast cancer is to do something about the weight. That does not mean that I don't sometimes give women who have this big increased risk HRT, because sometimes I know how are you going to go out and exercise or do anything healthy if you're having awful hot flushes and night sweats and you've not slept at all? But with counselling them, I might say, look, I'm willing to give you some HRT, but I want to see results. Because if this will then allow you to eat more healthily and go and do some exercise, and we can bring down that risk, then brilliant. And this is the really good bit of news, everyone. 7 fewer cases if you do 2.5 hours of moderate exercise per week. So get out there, girls. Right, okay, so the evidence. We've gone through this basically. Combined HRT does slightly increase the risk of breast cancer. It's about equivocal with estrogen only. Now, local estrogen, this is the treatment for those vaginal symptoms. There is no risk. It's been categorically proven that if you are on breast cancer treatment with tamoxifen, as long as your oncologist is aware, you can still use, with their understanding, vaginal estrogens. So vaginal estrogens used locally have no increased risk of breast cancer, but can massively reduce your vaginal symptoms and pelvic floor problems. HRT can reduce the risk of cardiovascular disease if taken in that window. So if taken within that 5-10 year window of you going into the menopause, if you've been without hormones for 10 years more, then it actually is going to increase your risk. Okay, just as we spoke before. Thank you. And HRT is really important for those women who are going through a very early menopause because of the risk of osteoporosis, cardiovascular disease, and their increased risk of dementia. Interestingly, there's no reduction in dementia risk if you take HRT as an older person, but if you take it as someone who's had a premature menopause, it reduces your risk of dementia. And those studies have shown that. So the rest of the story. So I want to hopefully give you a feel of what I try to cover with a patient unsuccessfully in 10 minutes. And I often have to do several bites at the cherry. But what I want you to understand is that for us as women, the menopause often happens as we are in that sandwich generation. We're often the busiest in our working lives. We may have children who are doing important exams. We may have parents who are needing care issues. And life is just massively difficult. So we need to be aware that I cannot, or a GP cannot with HRT, turn the clock back. It's not going to make you younger, but it may help with some of the symptoms. It may make life at work or at home more manageable until there becomes a time when you are ready to think about coming off the HRT. And we need to be aware that when we go through the menopause, we have got 30 plus more years of life, and we want them to be good years. Okay, so we want us to be looking at how we live this life fruitfully and joyously and not see it as the twilight. But I cannot deny we are getting grayer. Our cell production isn't as good and more diseases occur. So, and menopause is also a very, very sad time for a lot of people. And again, yesterday I had a very sad case of a lady with premature ovarian insufficiency who had not told a soul what she was going through. And she had been put on HRT, rightly, but she'd heard the risks that HRT increases your risk of breast cancer. She'd been suffering from 2 years of breast pain. She thinks that she's got cancer. She has not told a soul. She came in sobbing her eyes out. I was like, well, who have you told? No one. She's too ashamed about her diagnosis. And actually, we need to be aware that some of these women need psychological support and help from friends, family. There's things like the DAISY network for premature ovarian insufficiency, early menopause, but there are also menopause support groups. And it can be a sad time because it's a reminder that that period of your life is over. If you haven't had children, if you've always wanted them, it's a reminder that that time is gone. So it can be a sad time for people. It can be a relief for other people. If they've had awful endometriosis and fibroids and they've been bleeding and in pain every month, hallelujah, that is gone. So it's not all bad news. And we need to value wisdom and aging and actually see the benefits and look after one another and not put women down in the kitchens, right, where it's hot and sweaty. That's it. Thank you very much. So this is in your bags. And sometimes you just need to escape to it all, and that's my place that I go to escape.
We are running slightly behind, so I'm just going to crack on with some questions. They are hopefully coming up on the screen, but I'm going to start. I've got them here as well. Oh, here we go. There we go. So, how do we present with heart attacks? We'll start with that one.
Okay, so really good question. So men generally, and some women, will present with the I've got a crushing band around my chest, I feel like an elephant's on my chest, sweating, nausea, etc. There is evidence to say that women possibly, instead of clotting off the big arteries, it's the lots of little vessels. So they might get slightly more chest pain, but it's more diffuse. It's not quite so exertional angina that we would talk about with exercise-related shortness of breath and chest pain. It's just slightly the chest pain that's often ignored as sort of, because you don't have the classical signs that a man would often present with. And because doctors were always told chest pain, it's a crushing tight band around the chest, and it's like a pressure on your chest, and you're sweating and clammy, etc. That is a heart attack. Sometimes we just need to be aware that if a woman, particularly if she's got a family history or she's got high cholesterol, we should not be ignoring that, and we should be referring them up. I hope that answers your question slightly. It's just slightly more vague symptoms of chest pain.
Okay. Oh, look. Oh, they're changing all the time in front of me. Should we go for at what age will breast cancer be very unlikely to happen?
So breast cancer increases the older you get, basically. So the younger you are, the lower the risk of breast cancer is, except obviously there are some unfortunate genetic mutations that increase your risk in terms of family history, so the BRCA genes, etc. But generally speaking, as you get older, your risk increases. I don't have the figures with me, but basically it will end up being potentially 1 in 8 of us will get breast cancer in our lifetime. So it is common, but as you can see, treatment is so much better, so far fewer of us die. So it's about a tenfold, just under tenfold difference between breast cancer and heart disease in terms of death.
Brilliant. Should we go for next? If that one there that's been waved out, I've recently started on estrogen, menopause symptoms. How should I feel the benefits if I don't feel any different?
Okay. So, a very good question, and normally I would say some of the acute symptoms you might notice improvement within 2 to 3 weeks. So you may notice a few improvements fairly quickly. Some of the night problems, the brain fog, etc. may not improve for up to 3 months. Now, it's really important to be warned when you start HRT, particularly estrogen and estrogen progesterone, you are going to get some breast tenderness. So for women who've had babies, it's like the first trimester of a pregnancy, but you're going to feel that your breasts are more full and tender. You have not got breast cancer. Okay, that is quite normal, and it dies down within the first 2 to 3 months. If you have symptoms after that, do go and see your GP. But normally I would review my women between 2 to 3 months to find out how you're getting on. Are your symptoms improving? If not, yes, I would think about increasing the dosage. There are a few women who cannot absorb the estrogen through the route that it's been taken, and I might consider even changing the route of delivery, so a patch to oral, etc. And occasionally I will do estrogen levels. They're not definite, and I would try increasing the dose, increasing the dose up. But for some women, I will do what we call a trough level. So I ask you not to take your HRT that morning, do the blood test, and then you take your HRT so I can see what's going on in your blood.
Brilliant. We've probably only got time for 2 more, so...
You can email them to me.
Yeah, and Fiona will be around to chat to people afterwards. What about...
Yes, bone density and exercise, calcium, vitamin D, definitely. So really important bone loading exercises, yes please, for everyone to help maintain. You would though have to be of Olympic standard sports level to really improve your bone density massively just through exercise. Vitamin D, yes please, everyone in the UK through the winter, definitely vitamin D. And there's absolutely, so from September, October through to April, everyone should be taking vitamin D. And if you've got a low calcium diet, then you should be taking calcium supplements as well. Not everyone needs calcium, depending on what diet you're on. You can go to the British Dietetics Association website and you type in fact sheet calcium, comes up, and you can then see how much calcium you need in your diet for different ages.
And then should we do symptoms go away eventually as you get older?
For most women, yes. Hallelujah. So the average duration of symptoms is about 4 years. Some people think that actually it might be 10. Some lucky people are 1. I is going to feel really smug because she's likely to have the least symptoms because she's Japanese. So, okay, so if you're Japanese, you get the least symptoms, and if you're Afro-Caribbean or of African descent, you're likely to get the worst symptoms. And everyone else is somewhere in that range, okay? You are likely for the symptoms to disappear as you get older. Unfortunately, there are some women whose hot flushes come back as they get older. And we don't necessarily know why. We do know that stress and other life events do play a part in that as well. So yes, it is going to get better, and that's why I'd also suggest you wean slowly down off your HRT, because when you stop your HRT, it doesn't mean magically everything's going to be better, but either your symptoms have gone and you can cope with it, or you're in a better life phase and you can cope with it, or if your symptoms come back as you wean down, you're like, oh, I can't do this again, then with advice and reassurance and checking risk factors, you can go back up again. What we don't want is stop, start, stop, start, stop, start.
Is this a quick one? Are heart palpitations a sign of menopause?
Heart palpitations, yes, they can be, but I think there's also stuff about alcohol in there and caffeine and sugar and all sorts of things. So heart palpitations and anxiety and all those things, yes, can be a sign of menopause. They can also be a sign of thyroid disease, anxiety, too much caffeine. You know, there's a whole myriad of things, but yes, it is possible.
Brilliant. I think we're going to stop questions there because Corinne is going to come back down and interview Fiona. If your question is up there and it hasn't been answered,
come and find me.
Grab Fiona at the end. But we're just going to spend another 15 minutes or so now chatting to Fiona and finding out what a difference her faith makes to all of this, being a GP, dealing with all of the complications of not only prescribing and looking after people, but also in her own life, what a difference that all makes.
And just whilst Corinne comes to the front, just to let you know, I do have a few freebie samples. I'm sorry, I'm not meant to be promoting any particular company over anything else, but it's what I had left at work. So if anyone does have vaginal symptoms, I have got some samples of vaginal moisturiser, oil-based lubricants, and I think there might be some water-based lubricants, some information brochures. There's also stuff on the different forms of HRT, so I can go through that with you.
Brilliant. I was going to get us sitting down, and then I realised that I hadn't got a microphone if I sat down, so I think we might just say standing. So just wanted to quickly finish, because as I said, hopefully we will finish around kind of probably about 20 past 10. No, thank you, Fiona. Well, in fact, to start with, I just want to say thank you for just helping us and giving us so much information. So I think a big round of applause for all that. And as I think has been said, do feel free to stay around afterwards and ask Fiona some more questions if you'd like. But anyway, just I don't know whether this is a quickie or not to start with, but now I know that you're young enough not to be in the menopause yet. Now, is that something that you fear going through? How do you personally?
Yeah. Am I a fraud, is what she's saying. So I started learning much more about the menopause, obviously, when Isabel was 2. So at that point, it was way off my radar as I'm getting into my 40s and noticing that things aren't quite what they used to be. I am now 45. I am getting closer. Do I fear it? I think knowledge is power to a certain extent, and at least I am fully aware, and I won't be like a lot of my patients who come to me with all these symptoms and don't know what's going on with them, and I have to say, it's the menopause. I don't say that, I hasten to add. But at least I know when these symptoms start happening, and my poor husband gets told about the menopause repeatedly, so I think he'll be like, Fiona, go and see your GP and do something about it. The rest of the family are going completely crazy. So do I fear it? Not completely. I know that I am fearfully and wonderfully made. I know that God has designed me this way. Am I fearful of getting older? No, actually, I quite like it. I like having older children. I like actually not having the stress of trying to be young and youthful. I'm now in the veterans category for sporting events, so it does mean that I'm no longer competing with younger, fitter people. And actually, I think it's a lovely stage for us to start being able to actually say, that time of my life is past, but this time, I've got a different type of role. And I could talk about social prescribing and grandmother benches from Zimbabwe and the role of the older, wiser women. And in certain cultures, just to let you know, they, and certainly in the past, they used to think of blood as wise blood. So when you had your bleed each month, you were giving your wise blood to the next generation. However, when your bleeds stop, you contain your wise blood. So you become the wise woman. And then the women would then be the ones that you would go to in your group, your clan, to gain that knowledge and experience and wisdom from. And I think that's a lovely, lovely idea. And obviously we know that wise blood and containing blood. And I want to hasten to add, you do not contain this huge dam of blood inside you as you go through the menopause. But I think that's a lovely analogy. But I know that whatever I have to face, I've got a God who will be there with me. And the one bit that I do have to struggle with a little bit is the awareness that there is a bit in Galatians that says the fruit of the Spirit is love, joy, peace, patience, kindness, goodness, faithfulness, and self-control. Against such things there is no law. It doesn't say except when you're menopausal. So that is the bit that you're going to need to tell me, Fiona, when you shouted at that person, so I think it's being accountable to one another and actually saying, look, do you need to take a step back? And actually as friends with one another, you know, if times are tough and you've not slept and you're having awful hot flushes and night sweats, do we still put people on the rotas and expect people to do everything at work, etc., or do we make life easier for one another? And actually say, do you want to work from home for that day? Or staff uniforms, do we make it easier? Do we look at actually putting sanitary products in the bathrooms at work? Amazing, Kerry, Parsley, because of period poverty, we've actually got sanitary ware in the girls' toilets down here. But little things for when you're caught short. How do we look after one another? Yeah, so I don't completely fear it, but I will be coming to those of you who have been through it to find out how you coped.
Believe me, I think we still keep struggling with patience until the day we die. It doesn't go away, that struggle doesn't go away post-menopause. But you mentioned, Fiona, about being created by God, and as a Christian you believe that we're being created by a loving God and being designed this way. How do you kind of square it? To some extent you can look at this and see, well, it seemed to be a bit of a flaw in our design. How do you kind of square that circle as a Christian?
Okay, so I think there's two things here. We are designed in God's image, so we are designed and God isn't flawed. However, the world is not as it's meant to be. And there is a lot of, we are sinful, we have caused sin to happen in this world, our bodies age, they decay, and things happen. Who knows, before the fall, if menopause was ever going to be a thing? I don't know. But we can ask God when we get to heaven. So do I think it's a flaw of design? No. There is the benefit. If you're not continuing to produce children, some people don't like this analogy, but there is the thought that, and it's the grandmother killer whale, is if anyone has done any reading. Killer whales also go through the menopause. There you go. And the thought is that if they are not having their own children, they can support their child and their grandchildren. And there is a different role as we get older. If we are not concerned about children, we can actually have a different role to play.
Okay, thank you very much. And just one final question. How does being a Christian help you as a GP?
So, number one, don't be one of my patients because I run super late. Okay? So, what I would...
In my experience, a GP running super late is a sign of a good GP. Anyway, moving on.
Not if you're the 10th patient on the list. What I would say is that I take a real interest in the patient in terms of holistically, and you can be holistic without being a Christian. And by holistic, I'm meaning that I'm looking at not just the biomedical model, what medicine can I give you, but what else is going on in your life, psychologically, socially, what else is happening, and just be willing to ask a couple of questions. And I will sometimes ask, do you have a faith? What are you doing to help support you? Do you have friends, colleagues? What else are you doing that is helping this? And there are times that I will pray before a patient comes in, either because I know it's going to be a difficult consultation, please Lord, give me wisdom. I don't know how this is going to go. It went not so well last time. And sometimes if I've had a really difficult consultation with a patient that's made me really sad, I will pray silently about that patient afterwards and say, God, I don't know what to do. Please can you be with that young woman? So the young woman yesterday from Eritrea who socially and culturally for her, it's shameful. She is, you know, for her and her family, for her not to be able to have children and is mostly meaning that she's not got any chance of finding a husband.
Thank you very much, Fiona. I know that has been a kind of really, really quick little interview on your faith, but thank you for sharing with about that as well. But can I ask us once again to give a big thank you to Fiona?
You're most welcome. And this is a proverb from the Bible, but it says, Proverbs 16, verse 31, grey hair is a crown of glory. It is gained in a righteous life. So there you go. Those of you with grey hair, you've got a crown of glory. All right.